afternoon, ladies and gentlemen. First, I would like to thank AASD for inviting me to give this lecture. It's titled as Management of Newly Diagnosed Type 2 Diabetes, the debatable question, what's after Metformin? Through the next 15 minutes, I'm going to talk about diabetes prevalence in Egypt, what is the A1C target, and what is the phenomenon of clinical inertia, and what is the position of DPP-4 inhibitors and guidelines, and some evidence-based medicine about sitagliptin. This is the IDF Atlas for year 2019. If you look to the position of Egypt in this atlas, you found that Egypt ranked number 9 with number of patients, 8.9 million. It is expected to be number 8 at year 2030 with around 12 million patients. And at year 2045, it's expected that Egypt ranks number 7 with around 17 million patients. However, these numbers, I think, may be modulated by two factors. First, that Egypt have eradicated C hepatitis, and we all know that C hepatitis has been associated with the development of diabetes. Second, at the 100 million health initiative, Meet Million Saha, which have or may change these numbers according to the awareness and the discovery of many cases of diabetes during this initiative. Now look to the prevalence of cardiovascular disease and chronic kidney disease and type 2 diabetes. You will find that majority of type 2 diabetes have no cardiovascular disease nor chronic kidney disease. It's about 63% of patients may not have these two complications. About 15.5% they may have chronic kidney disease only. 13% they have cardiovascular disease only, and 8.6% have combined cardiovascular disease and chronic kidney disease. However, the duration of diabetes may be a parameter which should be taken in consideration. The earlier the diabetes, the less the presence of chronic kidney disease and cardiovascular disease. The later or the more progressed type 2 diabetes or more duration or longer duration of type 2 diabetes, you will find that we have more incidence of chronic kidney disease and cardiovascular disease. If we go back to UKPDS, we'll find that A1C has been associated with increased, higher A1C has been associated with increased microvascular complication. And as you see in this diagram, that for every 1% increase in A1C, there is 37% increase in the microvascular complication. The same for macrovascular complication. However, for every 1% increase in A1C, there are only about 13% increase in macrovascular complications. About the glycemic target, you all know that the standards of medical care of diabetes for the ADA at year 2021, A1C is less than 7%, preprandial capillary plasma glucose from 80 to 130 milligram per deciliter, peak postprandial capillary plasma glucose less than 180 milligram per deciliter. However, the target should be individualized according to several parameters. The risk of hypoglycemia, the disease duration, the life expectancy, what is the comorbidities associated with diabetes, is there is any established cardiovascular disease or vascular disease, what's about the patient attitude, what about the resources of financial supply for the patient. If we look to the first parameter, if it is high, we will have to talk less stringent. This means that's less tight, as we only accept more than 7% A1C. Okay. If the risk of hypoglycemia is low, we'll go to more stringent, more tight, less than 7% A1C. For disease duration, a long-standing duration, we may have a less stringent A1C, more than 7%. However, in the newly diagnosed, we may try to achieve an A1C less than 7, maybe 6.5. The same for life expectancy. If it is a short life expectancy, you will have a less stringent A1C. That means you will accept more than 7%. However, if it is a long life expectancy, you will accept an A1C less than 7, or we try to reach an A1C less than 7. If there is important comorbidities, you will have a severe comorbidities, you will go to the less stringent approach. However, if it is absent, you will go to the more stringent approach. For established cardiovascular disease, if it is severe, go to the less stringent. If it is absent, you go to less than 7%. Patient attitude, if the patient is motivated and want to be treated in a very good way, you will try to go to less than 7%. However, if the patient less motivated with poor self-care capabilities, you will go to less stringent, that's more than 70% A1C. Lastly, according to the financial condition of the patient, if it is limited, you will go to less stringent approach, and if it is available or financially supported in a way, you will go to the more stringent approach. In spite of this, a study published in year 2011 stated that even with the best available medical systems, the A1C at goal in the United States, for example, is only 52%. In Germany, only 40%. In France, only 41%. So we're still a way for controlling our patient because in spite of the good medical system and available supply for these patients. This leads us to the phenomenon of clinical inertia. What's clinical inertia? The patient is not intensified or have no intensified treatment in spite of being out of target. Okay, do you have a proof? Yes. So from the real world data, I want you to look to the black column. The black column are patients who have been out of range or out of target of A1C, yet no one intensified his treatment. For all patients, it's about 63%. For A1C from 7 to 7.9%, it is about 70. From 8 to 8.9%, it is 53. But if you look at the most important and most dangerous fact and alarming fact, that among patients with the highest A1C index category, it's more than 9%, there was no intensification in a 44% of patients. What happened if we didn't intensify in the right time? In this study from the United Kingdom, it's a retrospective cohort study published in year 2015. In this study, they revised the data from patients who have been out of target for 1 year. And the data for those have been controlled and intensified at right time. They followed them up and they find in the patients who have not received intensification just for 1 year, they have 67% of MI, 51% of stroke, 64% of heart failure, and the composite endpoints MI or stroke and heart failure are 62%. Around 3 years ago, a study combined DPP4 with inhibitor with metformin versus metformin alone, and they found that this new approach, that early combination between DPP4 and metformin, have been associated with sustained, prolonged response that maintain A1C better than metformin alone and better than the already established stepwise approach. That's what you mean, because a stepwise approach, you let your patient controlled for a while, then the patient go in a period of hyperglycemia, then control, then hyperglycemia, and this will lead to what we know, the phenomenon of metabolic memory, and the long-term complication will be increased in such patient. This is a patient profile of Mr. Farid. I just want you to see that he is a driver, so hypoglycemia is an issue. The patient have 5-year duration of diabetes, hypertensive, dyslipidemic, and have sustained slightly higher blood glucose reading. Currently he is in metformin 3 times daily and antihypertensive and hypolipidemic medication. You'll see that his A1C is 8.1%. The LDL is not within the target. Triglycerides is out of target. Creatinine is okay. So what to do for this patient? If we look to this slide, you know, all of you know this slide. You will find that DPP4 inhibitors and find in every approach. If you approach with cardiovascular disease, DPP4 is present. If you are looking to hypoglycemia, DPP4 is present. If you are looking for weight gain or weight loss, DPP4 is present. If you look even to the cost, DPP4 inhibitor is present. Because DPP4 combination with metformin will lead to metformin will lead to insulin sensitizing property, decrease hepatic glucose output by decrease of gluconeogenesis and glycosenolysis, sitagliptin decrease apoptosis and improve the markers of beta cell function and increase insulin synthesis and release. In addition, by suppression of glucagon from alpha cell, it leads to decrease of hepatic glucose output. When we look to the fixed dose combination between metformin and sitagliptin, Janomet, we'll find that even with the higher A1C, the patient have a considerable A1C reduction, it reaches 3.6%, and the lesser the A1C, the less the response. In addition, this effect is maintained through 30 weeks versus glimepiride. It was non-inferior when you add sitagliptin to metformin, and you add versus glimepiride to metformin, the A1C control was similar after 30 weeks. Again, this efficacy is maintained for a long period. This study for 5 years, 6 months, shows that the sulfonylurea have lose its control in A1C almost after 3 years. However, the sitagliptin control being prolonged up to 5 years or maintained up to 5 years. The same versus pioglitazone. In addition, the combination of sitagliptin plus metformin versus sulfonylurea plus metformin decreased the incidence of the percent of the patients likely to initiate insulin at about 24%. What about safety? We will find that sitagliptin among its class is one of the best as regards safety. The sitagliptin has no incidence of heart failure. The sitagliptin has no, like saxagliptin, okay, and the possible of allogliptin, possibility of heart failure allogliptin. Vildagliptin has no evidence of cardiovascular study, safety study. However, in real world data, it's safe. So the major adverse cardiovascular events are okay or good in patient of or limited, or is most the same as placebo in these studies. Let's look to the Takehome safety study. As you see, that the analysis for non-inferiority of composite and primary composite cardiovascular outcome of sitagliptin versus placebo shows there is no increased cardiovascular risk. The risk of hospitalization for heart failure, there is no between group different in hospitalization for heart failure. In around 14,000 patients from 25 randomized controlled trial, a meta-analysis have shown the following. Patients with sitagliptin versus the non-exposed groups, those who didn't take sitagliptin, have similar rate of cardiac disorder, bone fracture, infection, angioedema, and angioedema-related events, malignancies. And in addition, there is no increase in the risk of the pancreatitis. So we can say that the patient who takes sitagliptin is safe from many risks we know about other medication. So what's after metformin? This is the question we started the lecture with. We have a lot of consideration, as we see. Cost, and we said it's okay to give cost. There is a reasonable price for sitagliptin now. Hypoglycemia, it is not accompanied by hypoglycemia. Possible benefit, A1C reduction and sustained A1C reduction for sitagliptin. Side effects and tolerability, it's tolerable. Weight change, it has no effect on weight gain. The comorbidities, it has no effect on the progress of weight of comorbidities. And the take-home message show that glycemic control is a cornerstone of diabetes management. The key of management is individualization, according to the parameters we already discussed. And the decision should be based on evidence-based guidelines and the medical expertise of the physician. And finally, thank you.
Thank you very much, Professor Amr Abdel Wahab, for a very elegant presentation as usual. Dr. Amr Abdel Wahab, Professor Dr. Amr Abdel Wahab, elegantly presented that sitagliptin is effective with proven efficacy and safety. أنا هزود برضو And sitagliptin as a molecule, DPP4 inhibitor, does not need a prerequisite test for liver or kidney functions. لدرجة ان انا زي ما بقول لو انت مزنوق قوي وعيان مستعجل قوي حتى بالتليفون انت ممكن توصفه بالتليفون. نحب نأجل الأسئلة للآخر ولا نسأل دلوقتي؟ نأجل الأسئلة للآخر.